and welcome to episode 2 of Bloodwork. Today I'm going to be talking to you about a paper that came out just a few weeks ago in the Lancet Haematology, reporting the results of some clinical trials dating all the way back to 2012. Now, in these studies, the authors were looking at whether measurable residual disease monitoring in certain types of acute myeloid leukemia, or AML, actually improves the outcomes for these patients. So I touched briefly upon measurable residual disease in the last episode, but I want to explain now a little bit more about what it is, how it works, and why it can be tricky. So when a person is diagnosed with acute myeloid leukemia, it's very easy to see the leukemia cells because there are so many of these cancerous white blood cells in the blood. Now, a healthy person should have a white cell count of about 5 times 10 to the 9 per litre, which is about 1% of the blood. But in leukemia, we often see 10 times as many white blood cells, and in one very ill patient, I remember a white cell count of over 300. But this makes the leukemia cells very easy to detect. So, like this, you can see lots of white in among the red. And when we detect them, like this, it's very easy to see those white cells, right? Now, in a successful treatment, the leukemia cells will hopefully have gone away. Like this. And I don't think we can really see any cancer cells in here, right? But if the treatment has missed any, the patient's going to be in danger of relapse, or otherwise known as the cancer coming back. And knowing whether a patient needs further treatment or to go forward to a stem cell transplant, for example, is critical to prevent relapse. But these are also not risk-free, so we need to be as sure as possible. The trouble is that it's a lot harder to detect low numbers of leukemia cells with the more traditional lab techniques used for diagnosing leukemia, such as flow cytometry. And that's because to the machine, it looks a little bit like this. Was there a white cell in there or not? Would you be willing to bet your life that there was? That it wasn't just a trick of the light? Now, if we're taking a little bit of the bone marrow every 3 months to look in this way, we can see if the leukemia is coming back, but it can take some time to be sure for there to be enough white cells to detect, and this can potentially lose precious days or weeks that really will give the patient the best chance of survival. So instead, in these clinical trials, they used a method called quantitative PCR to look for the specific mutation that we know is causing the leukemia in the genes being expressed by the cells. And this is why the findings of this technique are sometimes also called molecular residual disease. We're looking for a specific molecule, as well as it being also called minimal or measurable residual disease. We call the whole lot MRD for short. And this is a much more sensitive and specific technique because it's looking in a totally different way. It's now really easy to see what we're looking for. Now, it can only be used for specific mutations in specific genes at this time, but one of these mutations is the NPM1 gene. And that's what the authors here looked for in nearly 300 patients across several years. And the NPM1 gene is one of the most common mutations in AML, affecting around about a third of patients. And NPM1 mutations also frequently co-occur with FLT3-ITD, which will be important in a minute. Now, where the NPM1 mutations were detected in these MRD settings, the treating clinicians were given the option of how best to treat the patients within their expertise, which is really important. So when the authors of the paper looked at the overall results, it seemed like it didn't actually matter if the patients were MRD positive or not. But when they looked closer, there's a significant survival benefit to those patients who had leukemia with both NPM1 mutation and FLT3-ITD mutations. So those patients who were not subject to monitoring, they had a 3-year survival rate of about 58%, whereas those patients where they looked for the monitoring, they predicted the relapse and treated them, they had a 3-year survival rate 69%. That's quite a significant increase. They could also show that the proportion of patients in which they detected the NPM1 signal increasing which is what they term molecular relapse, matched very closely to actual relapse of the disease in the patients who were not monitored in this way. So this means that it's working how we think it's working. Always reassuring. Now, since these trials ended in 2018, due to the long-term follow-up that's actually required, specific FLT3 inhibitors, such as gilteritinib, have been approved for FLT3-ITD AML, and there's evidence that these inhibitors may be of further benefit when used early in relapsing AML, highlighting again how important this kind of monitoring of residual disease is. So, brilliant stuff from the authors. And that brings me to the end. So I hope you found this interesting. Remember to please like and subscribe or comment if you've got any questions, any suggestions, and I'll see you next time.